This content is not designed for use as a medical reference to diagnose, treat, or prevent medical illnesses or trauma. If you have questions about the diagnosis, treatment, or prevention of a medical condition or illness, please consult your personal physician.
Welcome back, everyone. In the past few lectures, we've spent quite a bit of time talking about various forms of dementia. Today, we'll wrap up this conversation by discussing two additional types, frontotemporal dementia and Wernicke Korsakoff syndrome. As I'm sure you've realized by now, we have a lot to learn about all dementias, including their symptoms, what causes them, their underlying neuropathology, how to treat them, and how to distinguish them from one another. Even though we currently have no cure for any of the dementias, it's critical that we know how to distinguish different types from each other if we want to develop dementia-specific treatments. Let's get started with today's lecture by discussing frontotemporal dementia. This is an umbrella term for a group of neurodegenerative disorders that are characterized by progressive deficits in behavior, executive function, language, and often motor symptoms. Unlike other types of dementia that we've talked about thus far, frontotemporal dementia is typically seen in patients younger than 65. The average age of onset is actually between 45 and 65. Though it has been seen in individuals younger than 30 years and older than 65, such cases are rare. Symptoms of frontotemporal dementia can mimic those of psychiatric disorders, so it's really important that doctors rule those out before making a diagnosis. There are actually 3 different primary variants of frontotemporal dementia. Behavioral variant frontotemporal dementia is associated with early behavioral and executive function deficits. Non-fluent variant primary progressive aphasia is associated with progressive deficits in speech, grammar, and word output. And semantic variant primary progressive aphasia is associated with deficits in semantic knowledge and naming. With all 3 of these variants, patients at some point develop global cognitive impairments and motor deficits. Near the end stages of the disease, patients have difficulty eating, moving, and swallowing. In general, death usually follows on average 8 years after symptom onset and is typically caused by pneumonia or other secondary infections. Let's now take a closer look at our 3 variants, starting with behavioral variant frontotemporal dementia. This variant accounts for 60% of all frontotemporal dementia cases, so it is the most common of the 3. The most pronounced early symptom of behavioral variant frontotemporal dementia is personality changes, including greater disinhibition and apathy. Examples of disinhibition include displaying socially inappropriate behaviors, like approaching strangers without respect for physical or social boundaries, and engaging in impulsive or reckless actions, including new criminal behaviors, which is seen in 37 to 54% of patients. Other behavioral changes can include things like theft, urinating in public, unwanted sexual advances, and embarrassing personal remarks, such as telling off-color jokes, using crude language, or acting rude. Examples of apathy include a loss of sympathy and empathy toward family and friends, and a reduced interest in work, hobbies, social interactions, and hygiene. Keep in mind that apathy can often be mistaken for depression. Apathy can also present itself in the motor and cognitive domains. Patients with motor apathy exhibit a diminished drive to move, while those with cognitive apathy lose the desire to engage in goal-oriented activities. Patients with behavioral variant frontotemporal dementia also show perseverative, stereotyped, and compulsive or ritualistic behaviors, including simple repetitive movements and repetitive use of verbal phrases. Dietary changes are also common and include altered food preferences, with an increased consumption of sweets, alcohol, sometimes cigarettes, and binge eating. Hyperorality, or the tendency to put objects that aren't food in one's mouth, can also be seen, typically in later stages of the disease. Other symptoms include psychotic features, an altered sensitivity to pain, and altered temperature sensibility. So, for example, the patient might wear a winter coat when going outside on a 90-degree day. Moreover, mild features of motor neuron disease can occur in up to 40% of patients. Overall, patients seem not to realize that they are exhibiting changes in behavior. The second variant of frontotemporal dementia, non-fluent variant primary progressive aphasia, is associated with a progressive breakdown in language output with effortful non-fluent speech. Symptoms include slow, labored, and halting speech production with a misuse of grammar and word-finding difficulties. Patients also make speech sound errors, including using word insertions, deletions, substitutions, transpositions, and distortions. And finally, some patients maintain intact writing despite their deficits in spoken language. The third and final variant, semantic variant primary progressive aphasia, is associated with a progressive breakdown in semantic memory. As you may recall, this is the memory system that stores knowledge about objects and concepts based on our accumulated knowledge of the world as determined by our individual experiences over time. This variant affects vocabulary, specifically understanding the meaning of words. It also results in fluent but circumlocutory speech, like saying the thing that is used to cut paper instead of the word scissors. Patients will also experience difficulty retrieving names, using less precise vocabulary terms, and show impaired comprehension of word meanings. However, they will retain correct grammar and fluent speech. As the disease spreads from the temporal lobes into the frontal lobes, signs of irritability, emotional withdrawal, insomnia, and strict and selective eating will become apparent. Depression can arise too. One interesting aspect of this variant is that it can initially affect one temporal lobe more than the other before the disease becomes bilateral. Patients with the left temporal lobe variant present with issues involving the semantic meaning of words. The earliest symptom is often poor comprehension of single low-frequency words, giraffe for example, but perseveration, at least in the beginning stages, of high-frequency words, like dog. Those presenting with the right temporal lobe variant show behavioral changes like emotional distance, irritability, social isolation, bizarre alterations in dress, compulsions, and disruption of sleep, appetite, and libido. Individuals with this variant can also seem to lack social skills, telling long-winded stories, interrupting loved ones, and not picking up on normal cues that they are acting inappropriately. The compulsions some patients develop result from heightened activity in the side of the brain that's not affected by the disorder. For example, those with the left temporal lobe variant develop visual compulsions, since sight is more of a right temporal lobe function, like repetitively doing puzzles, beading jewelry, coin collecting, gardening, painting, and collecting brightly colored objects. And those with the right temporal lobe variant develop compulsions involving words and symbols, since language is more of a left temporal lobe function, such as compulsively writing down notes, letters, and telephone numbers, making puns, or playing solitaire. Some patients with a predominant left temporal lobe variant show an increased artistic ability, as this is a function of the right temporal lobe. Real-life cases include a 56-year-old businessman who developed a new passion for painting that led to him winning art awards. A 51-year-old housewife who began painting rivers and rural scenes she remembered from childhood, and a 53-year-old man with no prior interest in art who developed an intense desire to paint churches and haciendas that he remembered from childhood. This emergent creativity in frontotemporal dementia has also been noted in other abilities as well, such as photography, music, mechanics, and mathematics. Some frontotemporal dementia patients with a predominant right temporal lobe variant manifest a different kind of change in artistic expression. Their facial drawings are altered, suggesting a perception of others as being less human and more alien-like. These findings have led some scientists to ponder what the neuroanatomical schema is for artistic creativity. In other words, what makes us artistically creative? We know that the visual features of objects, such as shape, form, color, contrast, movement, etc., travel in separate pathways from the eyes to primary visual cortex in the back of the brain. Once there, visual information travels to the parietal and temporal lobes, where these different types of information are further analyzed. The right temporal lobe is believed to play a very important role in organizing these various visual elements into coherent and meaningful objects and visual scenes. This allows us to integrate and interpret the visual information we are seeing. And the ability to do these things plays a crucial role in artistic creativity. So it appears as though this ability can become heightened in patients who have damage to the left temporal lobe area, thereby leading to artistic creativity that is being driven by heightened activity in the right temporal lobe that did not previously exist. In terms of the neuropathology associated with frontotemporal dementia, MRI and CT scans generally show patterns of neuronal loss, gliosis, which is a process leading to scars in the central nervous system, and microvascular changes in the frontal lobes, temporal lobes, cingulate cortex, which is located above the corpus callosum and is involved with emotional responses, and insular cortex, which plays a role in sensory processing, decision-making, and motor control. Sometimes doctors do amyloid tracer imaging if they're trying to differentiate frontotemporal dementia from Alzheimer's disease. Tracer imaging is used to detect levels of amyloid in the brain. If amyloid is present, this indicates Alzheimer's, since frontotemporal dementia does not show any amyloid deposition. A family history is reported in up to 40% of cases of frontotemporal dementia, although a clear autosomal dominant history accounts for only 10% of cases. Autosomal means that the trait occurs due to a mutation in any chromosome from 1 to 22. Dominant means that only one copy of the mutation is needed for the disorder to be expressed. Mutations in specific genes, such as C90RF72, MAPT, and GRN, account for about 10 to 30% of inherited cases of the disorder. Frontotemporal dementia is believed to be a topathy, meaning it is associated with tau protein abnormalities in the brain. So how can we differentiate the symptoms of frontotemporal dementia from Alzheimer's? Well, frontotemporal dementia begins with distinct behavioral changes. So being socially inappropriate, apathetic, impulsive, etc. While people with Alzheimer's disease retain their social skills, but show memory problems early on. It is only as Alzheimer's disease progresses that the behavioral issues become more like those seen in frontotemporal dementia. Apathy is relatively mild in Alzheimer's patients compared to patients with frontotemporal dementia, in whom it is more pervasive and manifests either as a lack of concern for others or a lack of initiative. However, Alzheimer's patients have serious problems learning and retaining new information, whereas those with frontotemporal dementia usually know the day, the time, and where they are, and can keep track of recent events. Finally, whereas the risk of getting Alzheimer's disease increases with age, the risk of getting frontotemporal dementia decreases with age. Now that we've discussed frontotemporal dementia, let's turn our attention to Wernicke Korsakoff syndrome. This disorder starts off as Wernicke's encephalopathy, which can then progress to Korsakoff syndrome. Wernicke's encephalopathy is an acute neuropsychiatric disorder caused by a thiamine or vitamin B1 deficiency. Wernicke syndrome was first reported by Carl Wernicke in 1881 when he noted a triad of symptoms, first in a 20-year-old seamstress who attempted suicide by ingesting sulfuric acid, and later in 2 alcoholic men with delirium. This triad consisted of mental status changes, so a confused state, ataxia, so the loss of full control of bodily movements, and ocular abnormalities, like double vision, rapid involuntary eye movements, or nystagmus, paralysis of certain eye muscles, called ophthalmoplegia, and more rarely, drooping of the upper eyelids. Individual presentation of these symptoms can vary, and in fact, only 10 to 16% of patients present with all 3 symptoms. Other potential symptoms include lethargy, inattentiveness, drowsiness, and indifference. In 80 to 90% of cases, Wernicke's encephalopathy can progress to the more chronic Korsakoff syndrome, which is defined as an impairment in the formation of new memories while other mental functions remain more or less preserved. So earlier memories and general intelligence appear to be intact. Sergei Korsakoff discovered this disorder in 1887 after reporting patients with a peculiar amnesia for recent events. Korsakoff syndrome is primarily characterized by apathy and something called confabulation, which is when a patient unknowingly makes up stories to fill in gaps in their memory. In addition to apathy and confabulation, other possible cognitive impairments include attention deficits, trouble with abstract thinking, and difficulty regulating behaviors. Patients also exhibit apathy and lack awareness of their disabilities. Other symptoms of Korsakoff syndrome include peripheral neuropathy, which might cause weakness of the arms and legs, making it difficult for the patient to walk. Cardiovascular abnormalities may also be present, including a rapid heartbeat, low blood pressure upon standing, loss of consciousness, and hypothermia. Patients might also exhibit poor muscle coordination, unsteady gait, slow walking, rapid eye movements, paralysis of eye muscles, poor fine motor function, and decreased sense of smell. Interestingly enough, over the course of their lifetimes, neither Wernicke nor Korsakoff knew that the disorders they'd each discovered were actually related. Together, the 2 syndromes make up Wernicke-Korsakoff syndrome, with thiamine deficiency being the underlying cause of both. Thiamine is a water-soluble vitamin for glucose metabolism. So in other words, it helps the brain cells produce energy from sugar. A daily dose of 1.1 milligrams of thiamine for adult women and 1.2 milligrams of thiamine for adult men is recommended. Patients only exhibit neuropsychiatric symptoms if their thiamine levels fall below 20% of normal. Approximately 90% of cases of thiamine deficiency are seen in alcoholics, though it can also be seen in AIDS patients, individuals with anorexia nervosa, cancer patients, cases of starvation, chronic vomiting, kidney disorders, and chronic infection, and in patients who have undergone gastric bypass surgery. In chronic alcohol users, several factors lead to thiamine deficiency. One factor is that alcoholics tend to forego vitamin-rich foods in favor of vitamin-depleted, high-carbohydrate foods. So basically, they're not getting the adequate nutrition they need from food sources. In addition, alcoholics seem to have a reduced absorption of thiamine from the gut. And because renal epithelial cells are affected by alcohol, they also experience an increased thiamine loss from the kidneys. Thiamine storage capacity of the liver is also reduced. In fact, in chronic alcoholic liver disease, this storage capacity is reduced by 73%. Alcohol also reduces the enzymatic activity of thiamine pyrophosphokinase, TPK, which decreases the amount of thiamine uptake into cells. It also reduces the absorption of colonic bacterial thiamine, which would directly affect thiamine levels. And finally, hypomagnesemia is common in alcoholics, and magnesium is a necessary cofactor in thiamine utilization. In cases of Wernicke Korsakoff syndrome, where alcohol is not involved, thiamine deficiency is explained by one of four mechanisms. The first is decreased availability that develops due to starvation, malnutrition, malabsorption, excessive losses, and vomiting. The second is impaired utilization, which means the handling of thiamine is impaired due to low enzyme activity or associated coenzyme deficiencies. The third is accelerated usage, which develops when there is an overall increase in the body's metabolism of glucose. And the fourth is increased loss of thiamine, which can occur in dialysis as thiamine is removed. The earlier a person can receive treatment for Wernicke Korsakoff syndrome, the better their outcome will be. It's best to treat patients in the acute stages of Wernicke's encephalopathy before Korsakoff syndrome manifests itself. Intravenous thiamine replacement therapy is the treatment of choice for this disorder. Thiamine is given intravenously because abdominal absorption can be hampered in some individuals, and this therapy may continue daily for several months. Proper nutrition and hydration are also recommended, as is stopping the use of alcohol. Ceasing to drink alcohol and getting thiamine levels under control will prevent further damage to the brain and body. But many times, results are not reversible, especially if the individual has developed Korsakoff syndrome. A number of brain areas have been proposed as being involved in Wernicke Korsakoff syndrome, though not all peer-reviewed articles offer the same findings. Brain areas that do consistently appear across studies include the cerebellum, the frontal lobes, the thalamus, the hypothalamus, the periaqueductal gray matter, and the mammillary bodies. By now, you should be pretty familiar with the first four brain areas mentioned, but the last two we really haven't talked about. The periaqueductal gray matter is located in the midbrain. Although we don't completely understand this brain structure, it appears to have a number of different functions, including the modulation of pain, fear, and anxiety. It also interfaces with the medial frontal cortex and may contribute to behavioral and cognitive deficits. As to the mammillary bodies, these are part of the limbic system. You have one mammillary body on each side of your brain, and they play a role in the type of memory deficits that are evident in Wernicke Korsakoff syndrome. Okay, so at this point in the course, we've discussed 8 different types of dementia: Huntington's disease dementia, Creutzfeldt-Jakob disease dementia, Alzheimer's disease dementia, Parkinson's disease dementia, dementia with Lewy bodies, vascular dementia, frontotemporal dementia, and Wernicke Korsakoff syndrome. And these are only a small subset of the types of dementia that are out there. Because many dementia types have overlapping symptoms, it can be hard to distinguish one from the other. So to recap, here are the most distinct symptoms for each dementia we've discussed in the past few lectures. For Huntington's disease dementia, we have chorea, executive dysfunction, and movement issues such as bradykinesia, so slowness of movement, rigidity, akinesia, so difficulty starting movements, dysarthria, an abnormal rate and rhythm of speech, and dysphagia, problems swallowing food. For Creutzfeldt-Jakob disease dementia, a quick progression, frontal lobe deficits, and movement deficits including sudden jerky movements, impaired balance and falling, tremors and muscle weakness, muscle stiffness, muscle twitches, difficulty speaking, and difficulty swallowing. For Alzheimer's disease, memory loss and confusion, mood and personality changes, and trouble handling money or paying bills. For Lewy body disease, which includes Parkinson's disease dementia and dementia with Lewy bodies, fluctuating cognition, visual hallucinations, REM sleep behavior disorder, and cardinal symptoms of Parkinson's disease. For vascular dementia, abrupt onset, stepwise deterioration, and executive dysfunction. For frontotemporal dementia, diagnosis before the age of 65, disinhibition and apathy that appear very early in the disease, and compulsive behaviors. And finally, for Wernicke Korsakoff syndrome, confabulation, confusion and memory loss, and personality changes. Recall as well that patients can have mixed dementias, so more than one type of dementia at once, which makes diagnosis even more complicated. In addition, things like medications, depression, anxiety, stress, and so on can mimic some of these symptoms. Patients really need a complete physical with blood work, imaging scans, etc., to rule out a variety of potential causes. And as you've learned, many times a definitive diagnosis of a specific type of dementia cannot be made until an autopsy is performed. Here's hoping that with further advancements in science, including advances in imaging technology and neuropsychological testing, we will continue to further develop characteristics and behavioral profiles that are specific to these different types of dementias. Thanks so much for joining me today. In the next lecture, we'll discuss a disorder that many researchers believe precedes a diagnosis of dementia, mild cognitive impairment, or MCI. See you then.